Good afternoon, team, and welcome to Inspire Respiratory Critical Care's monthly Ask the Expert. We've been sort of doing or in the process of doing a what do the guidelines say sort of theme. So today we are going to talk about high flow nasal cannula. And before we get started, I'll introduce myself real quick. My name's Keith Lamb. I'm a respiratory therapist like many of you. I work at the University of Virginia on this trauma and surgical critical care service. And we'll start at the top with Tom. Introduce yourself.
Yep. My name is Thomas Prano. I'm a registered respiratory therapist and educator and consultant in Canada.
Andy.
Hi, my name is Andy Klein. I'm the adult clinical education coordinator and assistant professor at Rush University Medical Center in Chicago.
Joel.
Hello, I'm Joel Brown. I am the CEO of Arrive Leadership.
Donna.
Hi, I'm Donna Tanner. I'm a respiratory therapist in Cleveland, Ohio.
Eric.
Eric, you're muted.
You're muted. I think we do enough of these things now. My name is Eric Kreiner. I'm a clinical specialist respiratory therapist in Washington, D.C.
And it's a good thing, Eric, that your job doesn't require you to be knowledgeable about technology.
That's right. That's right. I'll bag the
data. John Wincott, flight respiratory therapist, Advent Health Orlando.
And Julie.
Julie Jackson. I'm a respiratory therapist, and I am also a clinical affairs specialist for Fisher and Paykel Healthcare.
And Karsten.
My name is Karsten Roberts. I'm an assistant teaching professor at Thomas Jefferson University in Philadelphia.
Excellent. So, Tom, if you want to pull up, can you pull up that first slide? So what we're going to do here is we are going to go over these talking points. And at the very end, or whenever we get to it, we will talk about the current guidelines and our interpretation of what they recommend in terms of high flow nasal cannula. So who wants to take a shot at? Oh, and by the way, go ahead and field. You can give input and questions as we go here in the chat box. And it looks like Hilton's on. Would like to get let in if you can.
I did. Yeah, he's in.
Perfect. And we'll go through and we'll just go back and forth and talk about these talking points. So anybody want to take a jab at just defining what high flow nasal cannula is? I would love to.
I don't always want to be the first one to talk, so I'm letting somebody else.
Well, I'll do it. Let me
go, Keith.
Let me see if I can take a stab at this. I'm no expert, but let me see if I can throw this out there. So any kind of high flow device to me is a device that either meets or exceeds the inspiratory flow requirement of a patient. And so since we know that the inspiratory flow requirement of an adult ICU patient can be 30, 35, 40, 45 or more liters, then a device, in order to be a high flow device, needs to provide at least that much flow. And the advantage of having a heated high flow device would be multifactorial. One is that it conditions and it provides water vapor and heated inspiratory gas. And one of the advantages of that specifically is that you can preserve mucociliary function. And some of the data that we have published shows that potentially you can decrease gram-negative infection and other bugs that might occur or the patient might be susceptible to. So high flow provides appropriate inspiratory flow, either meets or exceeds what the patient needs, provides heated and humidified inspired gas, may provide some expiratory positive pressure, which can benefit the patient in terms of decreasing work of breathing, can benefit the patient in terms of maybe help either reverse some atelectasis or prevent atelectasis. And of course, because it's a high flow device, it will provide F5.2 that's accurate, not like many other devices that is sort of dependent on air entrainment from the room and will will dilute inspired guess. So I think that's the basics. Anybody want to chime in and add on to that?
I just want to say, and I'll ask the rest of the panel, do you find the ambiguity in the description of high flow nasal cannula interchangeable with heated high flow? For instance, we all have patients on high flow cannulas at 10 liters per minute. But is it assumed that when we talk about high flow, we are talking about heated high flow?
This is Julie. I would say that there's a lot of confusion in the market because we use so much different terminology and we don't really, I think we would be better served. If you look at every journal, they ask you to use different terminology for the same concept. I think we would be better served if we said what the therapy is instead of the devices all the time. We tend to lean towards like the cannula, or we tend to lean towards a specific product device. I think we would be better served and people would have a better understanding if we actually talked more about in standardize the nomenclature to be about the therapy versus the delivery device or the type of product. That's my opinion.
That's good.
Oh,
Yeah, and I think it's important to understand that the definitions that are typically used really do imply cannula that is applied to the nasal cavity that has a flow that's so high that if you're not heating it, your patient would scream at you. Like, we are really talking about heated high flow when we talk about, and sometimes people use brand names. They'll say OptiFlow or Vapotherm or whatever. We're talking about flow that is significantly higher than what typical cannula are set at. And the only way it's possible is with humidification. I don't know if any of you have tried to bypass the humidifier on a high flow nasal cannula device. I have, just for fun, and it's not comfortable. Within 10 seconds, you want to pull it out of your nose. So that heated component is extremely important in one of the classifications, I think, for high flow nasal oxygen. But often the word humidified is taken out of that definition, and people just say high flow nasal oxygen. So someone's like, well, can't I just crank my nasal cannula like to a flow meter of max? I'm like, your patient's not going to like you. But that wouldn't follow under that definition, I think. So it's almost important that we add humidification to that definition, but often it's left out.
Completely agree. And John can speak to this too, but on the transport side, there's a lot of it being done, not heated. And I think it's torture.
Yeah. And there's no reason, but I'm going to give you a reason. By the time we get our patients into the aircraft, and if it's a short flight, 10, 15 minutes, the heater plate, is just now getting to a heated point where now we're going to take the patient off the aircraft. 1, 2, you can't get from bedside to aircraft with a heater on anyway. So we wrote our protocol to flights less than 30 minutes. As long as the liter flow is less than 40, then we don't humidify. We then can do passover humidification. But unless it's a longer flight with higher liter flow, it doesn't get heated. And that's another conversation we can have. But the transport theater presents some unique circumstances that, unfortunately, we don't have the same support that the ICU does. So,
I also think that because of the definition, right, and it's just not clarified, it's why it can make it really difficult as far as like research and trying to take studies that are alike. I remember a couple of years back, I had this slide that I did, and it showed how studies on high flow had like increased exponentially. But then if you looked at how they defined each one, like it almost flattened out, and especially after one of the vendors had switched and changed the name of what they do also. And it's like if you separate them out to what they do, then the studies didn't look as great as they did. If there was a clear definition of what it is. So I think often if you do a search, you have to really like read into the methods to make sure that they're all talking about the same thing.
Same thing, yeah.
I also think there's, by saying cannula all the time, we forget about those patients that have the ability to utilize a therapy via trach. And so it kind of implies that you can only do it with a cannula and you can't do it any other way. So I kind of worry about that a little bit as well for some people, because it gets confusing. Because when you do start talking about utilizing high flow therapy like post extubation on trach patients, or out on the floors, and you're using a special adapter for it, they get confused a lot of times, because we've always said cannula. So I don't know. I think there's we definitely need to figure out a way to standardize the terminology so that everyone's on the same page. But I don't know. We haven't even been able to figure out how to standardize vent terminology. So I'm not sure how we'll standardize this.
Right.
Yeah, I used to do a lecture on this topic, and I had one of my slides had about 40 different ways of describing just the nasal cannula, not even. And I think on our last discussion, we talked about trying to implement the term of non-invasive respiratory support more, instead of getting super granular about the interface. And so anyway, I think that I think for this discussion, it's become very common to use a device that provides heat, humidity, and high flow via a nasal cannula interface, regardless of the platform. And to Hollywood, to your point, if you really wanted to bad enough, couldn't you use a battery and a device that has a internal turbine to produce flow and stuff and transport on it?
Well, Joe had just pointed out to me there is an FDA approved battery now, so that's something that could be and probably should be considered.
Okay, yeah, I thought there was one out there. I just haven't seen it or used it. So, anybody want to try to start off the discussion about what kind of contraindications there might be for this therapy? Andy?
Well, one of the things, I'll start out with some of the obvious ones in my mind. Any sort of nasal or facial trauma, I think is a pretty slam dunk contraindication. Anybody who has some sort of aversion to having something in their nose. One of the things that's come up recently for us, and I don't know what you all think about this, but one of the things that's come up recently for us is, do you use high flow, high humidity nasal cannula on a patient that you're pretty sure probably needs to be on the ventilator, and you have them on high flow nasal cannula, and maybe you have them at a point where you're not panicking, but you're also not making that next move, and you're delaying essentially the next step in their care and things like that. So in my mind, that's starting to approach contraindication for me, at least relative contraindication. I don't want to put them on high flow nasal cannula and kick the can down the road for 6 hours, 12 hours, while the team's like, well, I mean, I'm okay with 90% on 60 liters and 100% high flow, high humidity nasal cannula.
I just, to be perfectly honest, I think we had this problem with COVID. Initially, people didn't want to use high flow because they felt there was a risk of, further infection or contamination of the room. They finally changed their opinions and started using it. At the same time, I want to highlight that adding a therapy like heated high flow nasal cannula doesn't negate your intubation criteria, right? So this is the problem. So I don't think it's a contraindication to use it when a patient needs to be intubated. I think the issue is that not recognizing the patient needs to be intubated, which is sort of beyond the fact that they're on it could be with any therapy, right? You could have them on NIV and you'd have the same problem, people using NIV and prolonging the inevitable. So if the patient is one that would allow intubation, like they're not a DNR, then I think it's a matter of the team still recognizing that you're not going to reduce mortality by avoiding the obvious intubation in a patient. So I feel like sometimes when we started using high flow, because we've heard of the studies that showed benefit, some people just started to ignore and completely forget criteria for intubating and just sat on patients for way too long. And of course, we've all seen patients that we've sat on way too long and they actually did okay. But I think it was when people were saying that, oh, we had a patient on 100% for 2 weeks and they did fine. I always pushed back and said, you should do an audit of all the patients that have been in that scenario and see how many of them got intubated before you make claims that, the patient will be fine. You should see how they do overall with this approach. Because I think overall you'd find that more people probably failed when you weren't on shift, and you came back a week later and, you had forgotten all about them.
So just to clarify, Tom, so what we're saying is, this is tongue in cheek, by the way, 70 liters of heated high flow and 100% non-rebreather mask is not okay.
No, yeah.
And again, this is tongue in cheek, and you saw some of that sometimes with COVID, but and Joe can attest to this. We're faced sometimes by going to some of these facilities where these folks are still using high flow off label at 70 liters and 100%. Mm-hmm. And that seems to be okay. And I had an instance the other day. One of our critical care teams calls and says, hey, I need your ventilator. Why do you need my ventilator? Well, because your ventilator goes to 70. No, it doesn't. It goes to 60, just like everybody else's. So you run into these crazy scenarios.
I'm going to jump in. The FDA does now. So Hollywood, the FDA does now in the US have an approved device that goes to 70 liters. Just so you know, there is approved devices now.
So, but again, I mean, fair enough. My equipment doesn't. So I'm faced with this. These are the limitations of the equipment that I have. So you kind of have to make do with that. So just little things, little nuances that, this patient did fine. The patient needs to be sat up and some deep breathing and stuff. But that's what we've seen sometimes. So
this is also a knowledge translation issue. So I can appreciate when FDA makes changes like this, but when they don't apply universally to all available devices, sometimes the knowledge translation gets a little bit messed up where someone's like, oh, I heard the FDA approved 70 liters per minute. So then everybody starts using it, not realizing that it's approved for devices that can actually meet the humidification demands of that flow rate. And this becomes a huge, obviously a huge problem with knowledge translation. So it's important that, when we, or any of us, anyone in a leadership position or an education position makes a claim like that we're very clear on that point, that if for devices that can do that, and if they're uncertain whether or not their device can do it, they should approach the manufacturer of the device or the provider of that device to be sure.
And I think he, just to finish the contraindication thought, I think you need to add severe hypercapnic respiratory failure, even in the setting of hypoxemic respiratory failure. I think NIV is still your method of choice in that patient population, even if they meet the hypoxemic criteria for high flow, high humidity nasal cannula as well.
Yeah, I was going to ask you what your thoughts on what level of hypercarbia was a contraindication to high flow. I think there's some decent literature out there that talks about that. Also, I wanted to address what you said about delaying definitive care, and this was pretty well covered by everybody. But it's always a concern about, no matter what our intervention is, delaying what could be a better intervention that might improve outcomes. And kind of piggybacking on that, the ROX index, or some sort of index that sort of is something that's verified that we can sort of predict failure from high flow nasal cannula. Anybody have any experience with that? I know everybody.
I mean, I've definitely calculated clinically. I think the limitation comes down to the thresholds that are used by people that utilize the ROX index. They have to understand that the paper that came up with specific thresholds was a specific population of patients. These were patients admitted with basically pneumonia only. So, hypoxemia caused by other causes. The absolute thresholds for when you should, possibly pay attention or make decisions may change based on the patient population in which you're calculating it on. But in terms of, presenting a risk, as with any score, I highly doubt that anyone's going to make a specific decision based on one value. So it was definitely something that I calculated to add it to the discussion, but it was never the definitive decision whether or not to intubate a patient on high flow. But it definitely added to the severity when utilized.
To answer your question, at Unity Point, we did add ROX index into our calculations. But to Tom's point, it was just one more piece of the puzzle. It wasn't our sole decision-making process. So assessment tools, looking at that as part of that assessment tool, but not a sole driver as to who's going to get tubed, who's not going to get tubed.
Yeah, I agree. I use it in my practice now, and like other things, it may be just a way of leveraging a next step if you think a next step is indicated. In other words, I would never use a number to make any decision for any patient for anything, like a pH, a CO2. It's not the one specific indice that's important. It's how that indice sort of plays in the big picture.
Yeah, it's part of a more of a holistic approach to assessing all potential risks and never just running with one.
Right. Hey, the pH is this, and this is happening, and the patient looks like this, and we need to intubate. That kind of thing. But
yeah. Now I say that, but of course, if patient stops breathing, that's one thing that would make me want to intubate them. Sometimes there is one thing that might happen, but in terms of scores and severity scores, yes, they're definitely just additive.
But they're going to get hypercarbic if they stop breathing.
Yeah, correct. Then you'll have multiple criteria. I think we can quickly just address this question here. I mean, we're going to get to the guidelines in a moment, but a patient that has pancreatitis, that is sort of irrelevant to the point. If you're talking about patients with ARDS, high flow nasal cannula is considered a better option than conventional oxygen therapy. But then you have to also realize that if the patient meets criteria for intubation after receiving high flow nasal cannula, in other words, if they don't improve, then obviously intubation may be a point. But pancreatitis is not a specific condition in which you would avoid high flow nasal cannula, and ARDS is an indication to actually try high flow nasal cannula if the patient doesn't already meet criteria for intubation. If anyone disagrees, I think it's a pretty straightforward question.
No, I certainly agree. It's interesting that somebody would ask specifically about pancreatitis, and I will tell you, in my experience, some of the sickest people I've ever had in my career have started out with pancreatitis. An etiology of ARDS that's pancreatitis. So maybe this person has that experience also.
Yeah, and I mean, I wouldn't be surprised if you told me a patient treated with high flow with pancreatitis and has ARDS eventually gets intubated. They are a pretty sick patient population, and I would agree. I think any of us that have had pancreatitis patients, as soon as you say your patient has pancreatitis, if they're not intubated, you're like, okay, well, we'll wait and see. But it's usually not a surprise if they do get intubated. It's a pretty significant condition.
So let me throw this out to just kind of, I guess, maybe sum that up, and then I'll end with kind of a question. So if we say the absolute contraindications where we can't use it or shouldn't use it is some sort of facial deformity or blocked nasal passages, something like that, right? Like you don't have a communicating operating anatomy for the application of the device. Everything else is kind of relative, wrapped up in the progression to a higher level of care, right? It's just kind of you kind of weed yourself through that. But one of the contraindications for non-invasive is this whole level of consciousness and secretion type of thing, right? And so it's kind of an interesting dilemma that we often find ourselves in is that we will not apply non-invasive because we readily say, oh, we shouldn't be putting non-invasive on this patient because of their neuro status. Put them on high flow, right? And so we're like, okay, all right. Well, so where do you guys sit on this? And they're on the side of the fence where they're not necessarily tipping towards a level of consciousness that demands an intubation, right, to absolutely protect an airway. But they have a level of consciousness that we wouldn't be placing them on non-invasive. So where do you guys? It's an interesting question that we always kind of have to navigate through because they're just picking something, right?
Yeah, I think traditionally this issue has been related to the fact of strapping a mask and covering the mouth, essentially, where if they were to vomit, not that high flow wouldn't be uncomfortable if you vomited while on high flow, but with your mouth not being covered, you at least have an exit. I think that's the biggest concern as to why we wouldn't. And even secretions, again, with NIV, just that limitation that if they cough, it's very difficult for them to get it away from the mask without just covering their face with their secretions if they have a decent cough. Whereas the high flow, again, whether or not it feels different to cough while wearing the high flow, it doesn't impede your ability to get it out of your mouth. I think that's probably so I can see why people would utilize high flow over NIV in someone with a decreased level of consciousness, assuming that it's not related to CO2. I think even if we actually had this discussion last time, we've all seen those frequent flyers that come into Emerge with very high CO2s that have a very low level of consciousness, and treated with NIV for 15 minutes, they're up and asking you for lunch. But that takes a little bit of practice and skill to recognize those patients and to treat them appropriately. But I think, to answer your question, I think the biggest concern comes down to the mask. I don't know if anyone else has any other comments with that, but I think that's the biggest concern, is just covering the mouth.
Yeah, the mask, right, is the thing, and especially someone in the peds world, right? We were really excited when high flow came and was being used on a regular basis because a kid doesn't know how to take a mask off, a full face mask off. So if they vomit or something like that, they're kind of at the will of hoping that an alarm goes off and someone knows. So that's why we always tend to lean towards it. It's just it didn't cover the mouth, but still cover all the needs as far as the patient's inspiratory flow is concerned.
Yeah, I still think from a neurostatus standpoint, to feed into Eric, though, you need to fall back on, can the patient clear the secretions? Can they cough? Can they swallow? If they can't, then you're playing with fire.
Yeah, I was gonna not add too much to this, but because I agree with everything everybody said, but the swallowing aspect of airway protection is probably more intact on high flow than it is on on BiPAP or with the mask. And I think that there's some data out there that talks about eating on high flow and some stuff that came out of Rush, Andy, too. I don't know how familiar you are with that data, but
yeah, we did some work with that with our speech language pathology staff to measure different leader flows and the sort of the subjective. We started with healthy volunteers, and then we've moved on. We're starting to collect some data on some actual patients. But we started with healthy volunteers and just got some subjective feedback on what the swallowing felt like at different leader flows and how confident they were with drinking and eating and things like that. And it's interesting.
Yeah. So let's move on. So we talked about contraindications. We didn't get really deep into hypercarbia, but we sort of know when somebody may be tipped over fairly easily that's hypercarbic and wouldn't be necessarily supported by high flow and might need some more aggressive non-invasive support. Advantages of high flow nasal cannula. Anybody want to try to hit on something that we haven't already talked about?
This is Julie. I want to hit on mobilization. It is a lot easier to mobilize patients on high flow nasal cannula than it is on non-invasive ventilation. They have to keep that mask on. You're kind of dinking around with the mask a lot when you're trying to mobilize them to get it secured, and it's just complicated with non-invasive. So I think it's just much easier to mobilize patients as long as you have all the appropriate equipment for mobilizing, depending on your device that you have. And I'm not going to get into that, but I think if you have all the appropriate equipment, I think it's a lot easier to mobilize them. And I think, my opinion, especially in the ICU setting, we don't have to give them as many drugs when they're on high flow versus when they're on non-invasive ventilation to kind of keep them in the bed or kind of keep them from pulling stuff off. So I think this is my opinion and what I've seen. I feel like the delirium risk kind of goes down a little bit too for them because we're not giving them all the added drugs. We can get them up, we can get them moving. So those are probably the two other things that I would say from my practice that I see a big difference for those patients.
I think we should clarify for any listeners or watchers, when you say the word mobilization, some people immediately think walking around the unit, and their brain's immediately going to, well, I can't walk them around with my device because it doesn't have a battery. We want to point out that mobilization can mean literally just standing the patient up and moving them around at the bedside. Like, you don't have to walk around the unit. Just getting the patient to stand up at the side of the bed is also considered mobilization. So if you have a device with a battery that can move the patients around, that's amazing. Or if you have some of the, they have the old setups for using high flow nasal cannula where you just have, a normal blender that doesn't require power, and you have a portable tank, you could bring that patient for short walks or whatever. But just the mobilization in general of getting the patient up into the bedside or even sitting up in the bed obviously is easier than having the full mask strapped to your face. But I just wanted to chime in just before someone's like, but we can't walk our patients around. Mobilization has different definitions.
Yeah, I would say the biggest advantage is the interface and compliance with it, right? And on top of that, the minimal amount of work needed to make sure that the therapy is continuing, meaning patient turns with a mask on, it comes halfway off their face. And then always going back to, my peds roots is it is so much easier to get a cannula on a kid than a mask. You have a kid that just maybe a little bit, in respiratory distress slightly, and then you try to put a mask on them and they're fully like in absolutely respiratory distress, mainly from the psych part of it and the blocking of their eyes. Kids don't like when their eyes are covered and they can't see what's in front of them. So to put a cannula on, it's so much easier, and we just get way more compliance from that. So to me, that is the biggest advantage outside of humidification, but definitely the interface is just patients are way more compliant.
I think anyone who's used high flow nasal cannula clinically knows that it is significantly more comfortable than NIV. I have met the odd patient who prefers their NIV over high flow, but they have many years of experience wearing a mask. They might wear CPAP at home. Like, some people are so accustomed to it that the high flow may feel strange to them. It is a different sensation, but I think overall we would all agree that patients generally find it more comfortable.
From a palliative care perspective, and by palliative care I mean just patient comfort and being able to have discussions. Palliative care does not always mean that the patient's going to die. Palliative care, patient comfort, patients can actually communicate better with the care staff and with their families. And if it does come to those end of life decisions, they can participate better in their decision making and advocate for themselves on high flow nasal cannula much more easily. And then, I know that Rush has published that data on being able to eat and drink and everything, but that's always what patients want when they come off they want to have a sip of water, and you can do that. I think the other big advantage that we haven't quite talked about yet, and there's some literature on it, but not a ton. Asked me 10 or 15 years ago whether or not we could deliver nebulizers through a high flow nasal cannula, and I said absolutely not. But now people are actually starting to research that. I think Jay has published a few papers on being able to actually deliver aerosol therapies through high flow nasal cannula, and that's got some it seems to seemingly has some advantages as well.
Yeah, I think another couple thoughts there. Number one, I this is my practice, but I feel like we are able to consider extubating patients sooner now that maybe are on a slightly higher level of oxygen on the vent. Usually you start thinking about, well, are they stable on 40% FiO2 before I start thinking about SBT and extubating them. I mean, if they're on 60% and otherwise rock solid stable, the conversation turns to, well, let's go ahead and extubate them because we can put them on high flow nasal cannula and get them off the vent a full day or more sooner, which is a huge advantage.
I really like that we've been discussing the advantages that aren't directly related to the guideline recommendations. So I think what we can do is, if anyone's thinking of bringing up or an advantage that has to do with the guideline, like, possible reduction in intubation or et cetera, we should probably wait till we get to the guidelines, because I think the clinical advantages that, patients may want to hear, obviously everything we've talked about with comfort, but I think what the data some people may or may not be surprised by the data. I think after the large Florali trial published in 2015 in New England Journal of Medicine, many people felt like, oh, it reduces mortality. And in that study, they did find a trend towards, well, they found reduced mortality. It was more specifically in the sicker patients even, which was surprising for some who had never used high flow before. And then we had this explosion, and maybe Julie, you could speak to the explosion if you have an affiliation with Fisher and Paykel. I think 2015 in the adult population, high flow nasal cannula exploded, right? Like after that Florali trial, it really did. There were some sites that were starting to utilize it. And after that, I felt like everyone was talking about it. All of a sudden, the list of publications for high flow just skyrocketed after 2015, particularly in the adult population. But in terms of those advantages, we'll get to probably wait till we get to the guidelines.
One other thing too, Tom, that's not in the guidelines that I think we've probably all experienced, and I know early in my career I didn't really care much about this because we weren't getting dinged for it, but that's skin breakdown. I mean, I think it's easier to manage skin breakdown if you are dealing with high flow nasal cannula, and we found some ways to really almost eliminate it at our facility with some of our preemptive things. But it's a real thing. I mean, as much as I don't want to say, you know, hey, skin breakdown is something super important in the ICU that we really need to worry about, even beyond, you know, making the patients better. But it is a real thing. We do need to think about it, and I think high flow nasal cannula does mitigate that some compared to a NIV mask.
Yep. And if anyone pays attention to the comments right now, you can see some people are discussing that at one site they noticed more skin breakdown than before. But at the same time, we have to also acknowledge the fact that before high flow, we only had NIV. So we probably use NIV a lot more than high flow. And I think now we're using high flow more than NIV. So if we're seeing more skin breakdown now with high flow versus NIV under certain situations, it might just be the fact that we're just using significantly more of that than we are with NIV. If we all know, we've all seen the pictures of NIV breakdown of the nose, and I think with like just horrible, you know, cavities in the nose. And I'm not sure that the skin breakdown is getting to that level with high flow. I don't disregard that there could be some skin integrity issues with high flow, but I don't think we're seeing to that level where, you know, we've seen the images published in Respiratory Care in previous studies just showing that cavity in the nose from the NIV breakdown. So just something to consider, that skin integrity is a spectrum, and I don't think we're seeing the spectrum that we saw with NIV, although we still may be seeing it, and, you know, still need to be considered or considerate of this possible breakdown. But just because it's not the extent of we saw with NIV doesn't mean it doesn't exist. So we still should be paying attention to skin integrity.
Yeah, and I put in the notes in there with that comment is that, you know, often folks, NIV, people are hypersensitive about it. And I remember we used to do like Q2, you know, assessments of skin integrity, but then once high flow came, there was none. And it was basically people waited, and then eventually they added it. So the question I asked was to make sure that, you know, whatever your assessment time for skin integrity is for your NIV, you're doing something similar for high flow. I think if you do that, I'd find it very unlikely, because of the pressure points, that you would have an increase in skin breakdown from using NIV. But Julie, I know this is your wheelhouse.
Well, this is from personal experience. I would say when we first started using high flow, I would say we saw about the same level of skin breakdown as what we were seeing with non-invasive. But I think it was because we weren't paying attention, and our nursing friends were trying to cinch it down just as tight as they were cinching down the masks. And so I think, to everyone's point, I think you have to look at how sick your patient is. What is their skin integrity when they walk through the door? What's their level of nutrition? Because if they have poor nutrition coming in, they're going to have poor skin integrity coming in. What are we doing to treat all that? And then we just need to treat it like it's non-invasive and just pay attention to it. Whether you document it or don't document it, I think is up to each institution. But we did document it with assessment, just like we did non-invasive. We paid attention to it. Sometimes for our non-invasive patients, to give them a break from non-invasive and the potential for skin integrity breakdown there, we would flip back and forth between high flow and non-invasive. So I think it's just really, really important that you pay attention to it regardless. I don't think it's any more or less. I think it's a matter of what's going on with your patient, what's your skin integrity to begin with, and are you paying attention to it? Like you would if they were intubated and you were moving tubes around, or like you would if they were non-invasive. it seemed to, it really, once we retrained and once we started paying attention to it, our skin breakdown issues went back to pretty much being nothing. But you have to pay attention.
Yeah, those are incredibly important points. I think all of us probably remember when people started using the anchor fast, we felt that, because it's got that, it's like designed for skincare and we don't have tapes. So we used to see a lot of skin breakdown from tapes falling in the mouth. And, all of the skin breakdown issues we had with tapes, we thought disappeared with the anchor fast. Then you start proning patients with the anchor fast and not paying attention to underneath the pads. And then some case reports in respiratory care where you peel back that pad and there's literally a cavity under the skin from the plastic piece that's on top of the pad. So anytime we change something that appears to be less of a problem than something we used historically, it doesn't mean that we should drop our guard and not pay close attention. And I think that was a perfect example of clinicians doing that, just feeling more safe with something, but then ignoring the fact that it could still have issues, and then not looking for them properly. So I think, as Julie mentioned, don't put your guard down on skin breakdown issues just because you've now used high flow more than NIV.
All really good points, and I want to just mention one thing because it's really a problem in some places, including the place that I practice. And this could be considered a disadvantage of sorts, the high flow nasal cannula. What if how many of you have limitations on where you can have a patient on high flow nasal cannula? In other words, at the University of Virginia, we can only have a patient on high flow nasal cannula that's in an ICU. And so because of that, there are limitations. You may be, as the clinician, you may be faced with reducing a support on a patient that's beneficial to the patient, just so that they can get moved out of the ICU. Or let's say you have somebody in the ER that gets placed on high flow nasal cannula, and I know Julie, your group that used to be my group as well, has done some work on this. But what if you have somebody in the ER and they can only go to the ICU? Does that make your decision making change some? In other words, do I say, okay, well, I'm not going to put this person on a high flow nasal cannula because they don't need an ICU for any other reason, so I'm going to give them support that's maybe not as beneficial as the support that I could give them? Anybody have any experience with that?
I do.
We have a lot of experience with that. We're kind of limited the same way you are, Keith, as far as we can only take them, on certain floors, our lung transplant floor, which is our monitored step down unit, and then our ICUs. But I think one of the major disadvantages is that we always look at this as rescue therapy versus frontline therapy.
Right.
We can use it on a few palliative floors for end of life, but it's very challenging. And I think it's hard because then we look at the fact of almost questioning our decision making. If I have a patient in the ED that I know is step down criteria, but isn't going to go to one of the floors, maybe going to a cardiac floor where we don't accept this, we change our modality. And I don't think we're doing the best thing for the patients that way.
Yeah, Keith, I would add to what you said, not only in terms of do we make the decision because we know they're going to have to be admitted to the ICU, but we literally just had this conversation earlier today. We had a patient on high flow nasal cannula at 50 liters and 50%. And the team came to do their rounds, the medical team. They're like, can we put them on the green high flow nasal cannula because we can't send them out of the unit? This patient's ready to go other than their oxygen demands. Can we put them on the green high flow at like 12 or 14 liters, which is, as you know, a much higher FiO2 than 50%. Plus, they lose the benefit of the potential, work of breathing benefit that you may get from the high flow nasal cannula. So they were putting pressure on to say, okay, well, let's quote unquote wean them to the green high flow tubing so that we can then have more options in terms of patient placement and things like that. So I think it's not just coming into the unit. I think it's the push to hurry up and get them out of the unit and making decisions based on that as well.
I think, Joel, with you having so much leadership experience, would you, so for those hospitals that don't allow high flow nasal cannula in the ward area, do you think it would be wise for a clinical educator or a practice lead to essentially present the data that exists that shows that high flow nasal cannula can reduce escalation of care in patients in hypoxemic failure? Because I think that that ability to avoid escalation of care means you may actually avoid needing a critical care bed if it could be utilized. Do you think those kind of arguments with that data are useful within a hospital setting?
Yeah,
I know in Canada they are, but I don't know, I know the US health system is very different than ours. I know that if you presented that data and made that argument, there may be limitations, like maybe, sorry, just to backtrack a little bit. In one of the hospitals I used to work at, we were allowed to use high flow, but there was a limit based on how much FiO2 they were on. So this didn't matter if it was high flow. If they got put on a non-rebreather, they were considered this criteria to then be escalated to further care. So we had an FiO2 limit rather than a device limit, if that makes sense.
You kind of beat me to it. Yeah, that's exactly the main point, right? Is that, the device itself versus the FiO2 required. The places, and especially even in consulting and the places I've worked, places are usually concerned about it. They go, if a patient needs that, are they so sick they should be in a unit that could be monitored a little better? But I think if you're just concerned about the device alone, then that's I don't think that's where it is. It's like, if they need it and they're on a FiO2, should that move them in that space? And it really depends on how risk averse the medical staff are. If you have a medical team that are very comfortable with their nurses and very comfortable with the respiratory therapists there, and you have the adequate number of therapists, because I find that smaller places struggle with it even more because there's just not a lot of us to keep track of that patient. So they put them where they can be observed the most. But I think if you lean further on the education of what the device does, and then talking about the FiO2 requirement along with the device requirement, then you're more likely to get it out of your ICU. Even in those places, though, a lot of them tend to focus on, in the step down unit, right? That's like the mid-level. And then if you're super successful, you can get them to understand at a level where they're comfortable with them being on a standard floor with standard monitoring. But again, the FiO2 is the main part, and your assessment of, obviously, if the person has even a slight amount of increased work of breathing, you don't want to try to convince them that they should stay there, because it's probably not a great idea. But the FiO2 is super important.
I think since we're talking disadvantages, just from me and Joe's perspective,
Keith, so obviously this is something that's like super near and dear to me.
Yeah.
So we published, I know it was a single center study, but we did publish on the implementation of high flow outside the ICU. And I think what this really, how we were successful is it comes down to a couple of things. Number one, it comes down to a standardized intentional protocol and what those tip-off limits are to who moves and who doesn't move to the ICU when you need them to. And it comes down to really good nursing education. Our nursing colleagues, they have no idea how high flow works. They're not taught this in the programs. They're not taught this in school. They don't understand the mechanisms behind this. So once you can get them over the hurdle of understanding, and there are tipping points, and I think, Joel, you might have said it, I think your institution or your physicians have to have some comfort level with the devices as well, and understanding who transfers when and where. But our study really kind of showed several things. It didn't show that we weren't escalating when we needed to. We actually escalated when we needed to, but our risk, or the number of patients needing to escalate, went down because we were actually being more proactive by implementing an intentional protocol and who went on when out on the general med surg floors. The number of rapid response calls went down because we were actually getting to the patients faster. Because we had tipping points and protocols as to when we were getting called to assess these patients. The mortality went down. Again, I believe that's because of an intentional protocol and RT assessments and looking at these patients faster. The ICU beds went down. We were actually able to, be able to keep patients out on the general med surg floor that maybe, for example, I'll just use this group. I know you all know this, but a lot of times we transfer those heart failure patients over to the ICU to put them on non-invasive for 4 hours. They come off after they get, Bumex or Lasix or whatever, and then you got to transfer them back out. Well, there's no bed when you want to transfer them back out. So really, that was just one population that we looked at too, where can we manage them over their acute respiratory distress on the floor long enough to do all the same therapy and not take up an ICU bed. So I think this comes down to an intentional protocol, good RT assessments, and good nursing education, along with physicians that are willing to support it. I think if you can do all those things, I think you can definitely manage these patients outside your ICU.
John, you were going to make a comment?
Just from a disadvantage perspective, and I hate to label a platform a disadvantage when it's purely trying to keep patients off mechanical ventilation, but a very strong precaution that I would urge is for patients that are being transported. We found a very, very glaring issue with oxygen consumption when it came to our aircraft. So you could transport somebody from an ICU out to the helicopter, and that can maybe take you 3-4 minutes, and you're going to bleed dry an E-tank just from having these guys on 60 liters and 100%. You can do this with non-invasive too. This is not singling out just heated high flow, but that is something that we noticed. We published in the Air Medical Journal on it. Of course, it maxes at 60 liters per minute. I'm going to have to go do some more thinking, but something to be cautious of if you're going to move a patient down to CAT scan, or you're going to move them somewhere else, that you do really take into consideration the O2 supply that you have, because you can bleed that dry very quickly.
Yeah, there's ambulance services now that won't even transport patients on high flow because their vehicles don't have the capacity to do it.
Yeah, so this might be a topic we have to have a part 2 on, to be honest with you. There's so much really,
Yeah, we've got 9 minutes to actually say what the guidelines say.
No, that's where I'm getting at. So we're gonna put the kibosh on any more talk about disadvantages.
Yeah, I think the disadvantages come around with the contraindications. Yeah. I think they kind of flow together. And I think what patients benefit most from high flow are going to be based on the guidelines, because the guidelines show the evidence whether or not they benefit the most from it. Right. Do we want to get into it, or do we want to say there's a part 2 in a couple of weeks? What do we do?
I don't know. Why don't we, for now, Tom, why don't you start taking us through the what the guidelines say?
Sure. Okay. So we do have a few guidelines. Maybe I'll just do a very quick summary, because I think we've already been talking about many of the subjects, but probably one of the more common ones right now is the ICM guidelines in 2020, led by Bram Rochberg, who is a Canadian physician with a McMaster affiliation. They had 4 PICO questions, essentially looking to see whether or not, so just for acute hypoxemic respiratory failure, they recommend high flow over conventional oxygen therapy. For peri-intubation, this is patients that you're about to intubate and you're wondering whether, when we pre-oxygenate patients pre-intubation, should we switch them to high flow to pre-oxygenate them? And they found they could not provide a recommendation, meaning the evidence was not sufficient enough to say that it was better than just increasing FiO2 pre-intubation. So there's again, if you're already on high flow, it doesn't suggest to change it, just continue using it for that purpose. But in terms of delaying intubation to go and get high flow equipment is not necessary. Post-extubation post-extubation respiratory failure, it says they suggest high flow over conventional following extubation for patients who are intubated more than 24 hours and have a high risk feature for failing intubation. For patients who clinicians would normally extubate to NIPPV, we suggest continued use of NIPPV as opposed to high flow. In other words, if your practice is currently to extubate high-risk people to high flow, to non-invasive ventilation, they don't say that you should change your practice to high flow, but high flow has been shown to be very similar in terms of reducing post-extubation failure. However, if your patient is hypercarbic at the time of extubation, you may want to lean towards non-invasive ventilation post-extubation, or maybe a combination of the two. Post-operative, so they recommend in high-risk or obese patients undergoing cardiac or thoracic surgery, they suggest using high flow over conventional oxygen therapy to prevent respiratory failure, which means essentially escalation of care and or possible intubation. So this is just a summary of those guidelines. So for hypoxemic respiratory failure, should you use conventional oxygen therapy or high flow? They strongly recommend using high flow for patients in hypoxic respiratory failure. After extubating patients, they have a conditional recommendation to utilize high flow nasal cannula. Again, if your patient's hypercarbic, you may want to lean towards the non-invasive route. And these are for patients immediately after extubation. This is not patients that fail 6 to 8 hours later. We had the same discussion with the NIV guidelines. You're not supposed to rescue patients with high flow or NIV. You should treat them prophylactically, so immediately extubating them to this therapy. Post-operative patients, conditional recommendation, and peri-intubation, no recommendation, but it was one of their PICO questions that they asked, which is why they chose to include this no recommendation. And then there was the ERS guidelines published 2 years later, somewhat similar, but they also included NIV in terms of their recommendations. So they found that for hypoxemic respiratory failure, high flow should be used over conventional oxygen therapy. For whether or not high flow or NIV should be used in patients with acute hypoxemic failure, they suggested the use of high flow over NIV in patients with acute hypoxic respiratory failure. I don't know that we'll have time for the new ARDS guidelines, but the new ARDS guidelines don't make a recommendation one over the other, except for COVID-19 patients. They actually suggest CPAP or NIV over high flow for COVID-19 patients, just based on the available evidence. PICO question 3, should high flow or conventional oxygen therapy be used during breaks from NIV? They recommend high flow over conventional therapy during breaks from NIV. So this is really this is a huge point for manufacturers of devices, that if your device does NIV, if it's an NIV capable device, having the ability to do high flow nasal cannula also would be ideal for a clinician scenario. You don't have to have 2 or 3 different devices in the room. If you're going to give people high flow in between NIV breaks, it'd be great for the device to have both options if it provides NIV. And then should high flow or conventional be used in post-operative patients? They suggest either conventional oxygen or high flow for post-operative patients at low risk of complications. So the higher risk patients, as the previous guideline suggested, should be using high flow nasal cannula. I sped through those. We have time for questions. If anyone has questions about those guidelines, I'll go back to the title of this more recent one, so people can sort of document this down or get this down.
Yeah, there's been a lot of background chatter. I'm sort of just now catching up on some of these comments. Any of these that anybody feels like they could effectively address? The last one by Kyle talks about thoughts on guidelines for high flow for trach patients. There's a lot of variation and practice variations in tracheostomized patients, and some people just use cool mist therapy, and some people use heated high flow.
Yeah, there's been a few studies that have compared at least physiological variables, and if I recall, they didn't find a significant difference. It is a very different system. Although it's very convenient, I personally like the OptiTrach cannula. I like that it's a very nice device, etc. But it is a much more open system than high flow nasal cannula. High flow nasal cannula, fits in the nose. It has that ability to sort of generate a little bit of expiratory resistance when patients are breathing, which can have some physiological benefits. But with the trach, it is a wide open system, and I don't know that they've found significant changes in work of breathing, at least in the one study. I believe it was published in Respiratory Care, if someone recalls that paper. And it was just comparing tracheostomy with just a trach hood versus the OptiTrach.
Yeah, I'm not familiar with that literature.
I think another thing to consider also, Tom, is the humidity aspect. I think you touched on it, but some of our patients that we will use high flow therapy on, it's because we don't use things like it's escaping me. We used to put them around the large volume nebs. They'd get heated up and they'd melt the plastic and all those things. The collar humidifiers.
Heater collars,
the donut heaters. Sorry.
Donut heaters.
But I can tell you that since we've had the option to use the trach adapter on the high flow nasal cannula on those patients, especially with thick secretions that we're really struggling with, humidifying the secretion is a little bit better with the heated humidity. And again, to your point from earlier, these are patients that are requiring very low amounts of FiO2, and that we're really just on it for the humidity and the additional, secretion management aspect of that. We've seen some success in that population as well by using those, by using high flow as opposed to just regular large volume neb.
Yeah, I'll go forward.
Keith, one other thing. Go ahead, Joe.
I was just going to say, I'll do full administrator on the one about I'm using it for trach patients, and going back to what Tom was saying, if there's no any evidence showing there's an increase and improvement, that there's definitely a difference in cost. So I wonder how much that had to do with them not allowing it.
I think the other thing we have to consider, and this comes up a lot too, and it came up at our institution, is if that trach patient's going to discharge somewhere, they're likely not discharging on high flow. And they're not discharging with whatever system it might be. They're going to discharge to either skilled nursing, rehab, nursing home, or home with a trach collar, because that's what's provided in those areas. So I think even when you are maybe utilizing a heated system for them while they're in the hospital, you're going to have to start thinking about what's going to happen closer to discharge, because a lot of places, in my experience, has been when we first started saying that they were on high flow with the trach adapter, they wouldn't take them because they didn't have the system, and so they would reject them. So I think you also have to kind of think about that and what your plan's going to be before discharge for those patients.
Great point.
All right. Well, it looks like our time is sort of up. Anybody have any last second wrap up points they want to make? I think we'll think about what our next topic is going to be, but maybe we could have another one of these that sort of wraps up NIV and high flow all at the same time, something like that with more more detail. So I will wrap this up. I want to say thanks to the panelists. For those of you who are listening or paying attention now, all these guys are volunteers. We all are. We just are really passionate about teaching and learning. We've all talked in the background about how much more we all get out of doing this than we could possibly fathom that anybody else would get out of it. So that's really the spirit of this, and we hope that everybody enjoyed this presentation. As soon as we get finished here, Tom will make a video out of this thing, send it to me, and I'll get it up on our YouTube channel. And Madison put a link there that you can go to recommend future topics. And we appreciate everybody's participation. So with all of that, I want to thank you once again, and thanks for the participants. And you guys have a great afternoon, and thanks again.
Thank you.